once again, we're pleased to be bringing you this IHSPR policy round, which will share findings from research supported through CIHR's Partnerships for Health System Improvement, or FISI program. FISI grants support teams of researchers and decision makers interested in conducting applied and policy-relevant health systems and services research that responds to the needs of healthcare decision makers and strengthens the Canadian healthcare system. For more information about recent FISI opportunities, you can visit our website, and Howell will post that there on the right-hand side of the screen for you to see. The learning objectives for today are for researchers and policymakers involved with e-health or sexual health services to learn about the BC experience with developing an internet-based testing program, to hear about the outcomes of integrating research with program development in terms of optimal service design and delivery, and to consider how a combination of research approaches can be leveraged to broadly assess health system impacts of online interventions at multiple levels from start to finish. In terms of an outline for the session today, we'll jump right into some speaker introductions, and then Mark and Jeannie will provide some background and context, and as well as an overview of their research, discuss the policy implications, and then we'll move into a question and answer period, followed by an evaluation, which will pop up at the end of the webinar. We'd just like to acknowledge that today's webinar, though hosted by CIHR, is a true collaboration among all the organizations listed here, including the University of British Columbia, the BC Centre for Disease Control, and the BC Online Sexual Health Services. I'll hand it over now to our two capable presenters today, Jeannie Shuffler and Mark Gilbert, who will introduce themselves and talk a little bit more about their roles in relation to BC's internet-based testing program for STIs. I'll pass it over to you, Mark.
Great. Thanks, Amanda. Thanks to everyone for dialing in, and Jeannie and I are both really excited to tell you a bit of the story about what we've been doing over the past several years in terms of developing this new program, Get Checked Online, which is our internet testing program. So we just thought it'd be helpful to start out with a discussion of the fact that probably like most of the people on the call, we have multiple hats that we wear at different times, and I thought it'd be helpful to at least explain to you the hats that we're sort of bringing to the presentation today. So I'm Mark Gilbert. I work at the BC Centre for Disease Control leading the Online Sexual Health Services program, which is the program responsible for building Get Checked Online. And so I wear a very strong hat as a knowledge user around the research findings that come out of this work that we're doing. I also have an appointment at the University of British Columbia, and so I am also a researcher and sort of have that joint program user researcher hat as well. Also, just to acknowledge that I'm in transition to a position in Ontario at the Ontario HIV Treatment Network, and there, as I participate in this research going forward, I'll also have that added hat of thinking about how we can use these findings to scale up potentially or introduce it into other jurisdictions. So over to you, Jeannie.
And good morning. Thank you, Mark. Good morning, everyone. My name is Jeannie Shuffler, and I'm a professor at UBC's School of Population and Public Health. I'm a researcher primarily, and I also have an opportunity through my research and my teaching here at the school to engage with a number of trainees. And later on in our presentation this morning, Mark and I will both be referring to work that has really been instigated and spearheaded in collaboration with several of our trainees, and we're really pleased to be able to talk about those pieces today as well. Back to you, Mark.
Great. We'll dive right into the presentation then. So really the objectives, in addition to sort of the learning objectives described today, it's really overall to describe how a program of research based on an integrated knowledge translation approach is being used for the design, implementation, evaluation, and scale-up of Get Checked Online. And right from the beginning of our work on this project, we've had a very deliberate strategy of embedding research and evaluation at all steps of program development, and see it very much as an iterative cycle over time. So the four main parts of our presentation will describe first the landscape of e-health research and STI prevention, then talk about internet-based testing for STIs and HIV, and then really focus in on our program of research and some of our findings to date, and then wrap up with our lessons learned. So first, just wanted to cover some of the broad landscape of e-health research and STI prevention. So this data is a bit outdated. This comes from the Pew Internet, which is a great source of information about use of the Internet. But this is stats from 2011, and surely the engagement today is even more profound. And we know that the majority of the population do actually turn to the Internet for health information of some sort. Some are just passive consumers where they're looking for health information online. Some, a smaller group, are actually fairly active consumers. So they're posting about their own drug or treatment experience or posting information to a health website. And really, I think, as we all know, that the Internet is a major driving force when we think about access to appropriate health care, and now a new form for thinking about delivery of services. So what we're talking about here in particular is sexual health services. So when I say sexual health services and by our online sexual health services program, we're thinking quite broadly around general domains of testing, treatment, contraception, and counseling related to sexual health. And we know in Canada, in BC particularly, as well as in other parts of Canada, that there are clear disparities in both access to sexual health services, particularly, for example, for rural versus urban areas. And we also know there's disparities in burden. These are not infections that are randomly distributed across the population. They're concentrated in particular populations that have a higher prevalence of disease. We also know over time, and I'm sure this is an experience in other provinces, that there have been increased service demands. So we've been seeing both increasing numbers of diagnoses of STIs, particularly chlamydia, as well as gonorrhea. And we know that there are delays to care because of the sort of increased burden and increased client volume that may be leading to misprevention opportunities. And just to flag that we know that, because this will come up later, that you know, a large portion of our sexual health services are consumed by people who don't necessarily have any pressing concerns, but they're looking for asymptomatic screening or asymptomatic testing. And so we have to think about new ways to try to deal with some of these demands. So the notion of how this fits with the Internet first emerged sort of in the sexual health or STI literature back in 2000 with this report, which was a report from San Francisco where a syphilis outbreak amongst men who have sex with men in that city was traced to a chat room. And it wasn't just the first notification that an online space was proving critical to disease transmission, but it also was the first example that I know of public health staff then going into that online environment to find partners and advise about testing and treatment. So this sort of led to sort of what people were calling a new era of STI prevention, really recognizing the potential for the Internet and now other mobile technologies to really enhance STI prevention. And we've seen a variety of different kinds of online interventions that have emerged as a result. And the one that I'll be focusing on today that Gina was talking about is Internet-based testing. So the rationale for these online applications of sexual health services is they're perceived and they're known from research to be highly acceptable. They're very much a patient-centered approach. You're giving control into the hands of patients versus being a provider-gated approaches to health services. There is clearly a unique sort of ability to potentially reach populations affected by sexually transmitted infections and the potential to reduce some of the many barriers to access of these services that we know exist. Online services, because they are sort of a programmer application, can provide a consistent quality, and potentially if some of people's sexual health needs are met online, it can mean a better use of clinician resources. While there's not much information about this, online interventions are thought to be cost-effective in the end, and there's also thought to be economies of scale. If you build something for one jurisdiction, it potentially can be expanded and scaled up to others. So over to you, Jeannie.
Thank you, Mark. We also know from our previous research that while conventional services play a very important and fundamental role to reaching key populations with concerns around STI risk, for example, young people or men who have sex with men, we also know that for almost every population and subgroup of that population, there is a degree of barrier to being able to access conventional services. We also recognize that in many places, conventional services are stretched to their max and are not receiving additional resources that might let them grow and build to address a growing need in terms of service provision. In terms of thinking through some of the barriers, you can imagine, I'm sure some of you have very, very practical understandings of some of these barriers from your own work perspective. But just to give you a couple of examples to think about as we work through the presentation, face-to-face provision of services have been shown to be potentially stigmatizing experiences because of the remaining stigma even in today's world around STIs and HIV, and the stigmas associated with patients' various social positions. We also know that for many patients, it's a challenge to geographically access clinical, conventional-based services. Clinic hours don't always match up with the real-life needs of patients. And we've also learned from our work, particularly with young people, that clinic waiting areas are not always viewed as the most friendly and welcoming spaces. So to be able to offer an option for folks to be able to access services, STI testing services in an online environment is really meant as a way to begin to address some aspects of these kinds of barriers to conventional service provision and also open up new avenues. But many questions remain. Although e-health interventions, as Mark has described earlier, have been shown to be feasible in other settings, we don't know, or we didn't know 5 years ago when we began this initiative, how well this kind of approach to e-health might work in British Columbia. There are challenges even facing thinking about implementing e-health intervention services, and these include things like oftentimes in many settings, the folks who are tasked with taking up and promoting an intervention innovation such as e-health intervention are not only caught, being responsible for taking the initiative and implementing and developing that initiative, but also tasked with evaluating it. And that kind of developing and deploying energy and resource that is required, in addition to the evaluation piece, is that, sometimes beyond the reach of some units. Despite the fact that there is a growing emerging evidence base to show that, moving into and taking up new technologies is, a really important way forward in terms of complementing conventional approaches. Now, that is not to say that, and we know that there are huge challenges in terms of the adoption of new technologies. The business literature has showed us this, that adoption of new technologies is something that in particular, government has had not a great reputation and not a great set of innovation experiences, being rather slow to take up, and perhaps some might even say resistant to taking up new technologies. However, if we think, oops, I don't know how. Let me go back.
Sorry, Jeannie, you got to remind me as well to move forward, I think.
Oh, I thought I was moving forward. I'm so sorry, Mark.
Nope.
We're on recurring problems.
Okay, sorry. Well, I'll just pause here because this is such a great slide to let people see the adoption of these technologies. Yes. All right, recurring problems.
Thank you, Mark. Sorry about that. It's
No
still
problem.
early here. So yes, recurring problems of e-health interventions. It is a challenge, and these have been described in the business literature as well. But, the kind of financial capacity to actually immediately take up and test and experiment with innovation in an environment where governments are facing, huge reporting in responsibilities and not many increases in budget lines, this is a real challenge. To be nimble and take things up quickly and assess them effectively. Certainly in many environments, and again, many of the listeners will be familiar with this, the kind of legislative and policy environment, particularly around privacy, for example, might kind of lag behind what 2014-15 needs might look like. there is a documented reticence. Again, I think the previous slide did a nice job of illustrating that, where people do remain suspicious, and it is one of those situations where you find a bit of reluctance, even in some parties that you might normally think of as progressive. Thinking as well about focusing exclusively on the technological, or what some might call engineering-driven solutions and approaches, rather than thinking through the fact that any kind of engineering-driven solution is also, in fact, a social interaction, a social innovation within a system, including healthcare systems. There's also some evidence to show that the way in which we end up deploying interventions like e-health interventions happens in that kind of piecemeal. We get a little bit of money to do one part of it, a little bit of money to do another part of it 3 years later, and that makes it a real challenge to kind of scale up effectively. And again, there are a number of other challenges that face the introduction of e-health interventions, and I think in each of our settings we can imagine and realize what some of those are. So let's go to the next slide, please, Mark. Thank you. In our work, we recognized the fact that e-health intervention is not necessarily a de rigueur of moving forward, but we also recognized, as Mark has said, that the Internet presents a really promising medium with perhaps unprecedented reach to important populations who are at risk of STI locally and globally, for that matter. So drawing on the evidence that we had at hand in 2009, we really began to work together on developing a really applied research decision-making partnership to begin to understand what we saw as a really important question in the development and implementation of the online sexual health services program. And that was to understand the intervention context itself. So often, intervention research sort of, if you will, jumps that research to practice gap without fully investigating and fully trying to understand the dynamics and the contextual features of the implementation context. And we really felt like it was very important for us, if we were to put an effort together to launch a comprehensive e-health intervention in the area of STI testing online, that we needed to commit also to understanding the intervention context that we were working within. Next slide, please. We conceptualized our work in thinking about the environment or the context where we were working. We drew on theories and approaches related to complex adaptive systems thinking. And we did this because we were very interested in focusing both on systems level structural pieces, so how could and how would our system absorb and rub up against the introduction of an innovation like online testing, what kind of information exchange mechanisms might be appropriate or applicable for helping with scaling up, what policies, procedures, and regulations, or even legislations would need to be considered in the implementation. And of course, we were very interested in pieces pertaining to the health human resource workforce within BC's STI testing and service provision system. Clinicians, laboratories, and other partners and other program staff. So we thought very carefully about sort of the intramural world of implementing the online service programs, but we also thought very carefully as well about the extramural collection, so the external connections that the program would need to fit up against in terms of the broader context of healthcare provision writ large in British Columbia, including thinking about the ways in which scope of practice and accreditation bodies like the College of Nurses or the College of Physicians and Surgeons might be able to help us understand how to better develop and implement an effective online STI testing approach. In particular, our relationships and our thinking with respect to regional health authorities and NGOs like Options for Sexual Health here in British Columbia, who do a large part of the service provision in over 50 clinics across the province. These were key pieces for us to understand to help us think through how we might work carefully with service providers and decision makers to implement the online services program. I share with you this slide that looks like a puddle in nature. Sorry, I didn't want to say puddle in nature. Sorry, Mark. This slide that looks like a puddle in nature, only to say that this is one example, just like the online service provision system and the sexual health service provision system in British Columbia is an example of a complex adaptive system. So too is any system that demonstrates these kind of characteristics, these hallmarks of complex adaptive systems. There are only two pieces that I really want to draw your attention to at this point. And one is the bottom point around adaptive capacity, because I think this is going to come up again in our presentation. And this relates to the idea that we learn, institutions learn and use stored knowledge to solve problems in the current context, but we also draw on that into the future context. And so lessons learned from other experiences with e-health interventions, for example, like the electronic health records, certainly have informed the planning process around online sexual health approaches. And learning through other experiences really, I think, has been a great way of helping us think through impacts of introducing another new e-health service on things like workflow, human health resource management, and of course, if you can go to the next slide, please, Mark, issues to do with complexity. And this, I just want to say a very brief word about complexity. All of you can imagine that in a system that is both geographically dispersed as well as centrally defined around a set of specific tasks, that there might be unique relationships across communities of interest, across understanding how different underlying disease incidents or social norms might affect scaling up of an online service program. So this is not a simple one-way, take an intervention and inject it into a system. It is indeed very complex. If you could go to the next slide, please, Mark. Thank you. So our efforts have been really around trying to identify how to bring I guess, a convergence, if you will, bringing together the notion that we can develop and evaluate this kind of e-health intervention, looking to the literature, thinking about implementation science. And Mark, I think, earlier brought up the notion of program science. And I think that there are a lot of kind of analogous relationships that we drew on between what I already know about introductions of e-health technologies, what we already know about the conventional system of STI provision, and we really have tried to take a multidisciplinary, multi-method, engaging, ongoing cycle of evaluation and implementation approach to this project. And that requires ongoing information on a very continuous basis. And I think at this point I'll turn it back to Mark, who will talk a little bit more about that.
All right. Thank you, Jeannie. So I'm sure many people on the call are wondering, maybe this is the first time you're hearing about internet-based testing and wondering what it's all about. So this next session will just give you a bit of background about that. And drawing on our program in BC, Get Checked Online, which is just launched. So what in general is internet-based testing? So the basic premise of internet-based testing programs are that a person can access testing for STIs and HIV through a website. And in our case, by printing off a laboratory requisition. In other programs, it can involve ordering a self-collection kit, for example, but getting results online or by phone. But the basic concept is not requiring someone to come into a clinic or into their GP's office to get a test requisition or to get the test ordered. Again, the rationale is very similar to what we talked about earlier, but in particular, we know that there are key barriers to accessing testing, some of which Jeannie talked about earlier. In particular, we want to try to improve test uptake, so people who aren't engaged in testing, but also increasing the frequency of testing amongst people already engaged in testing, but where sort of a convenient more form of testing may have a positive impact on test frequency. The other rationale is about, again, if we can shift some of those asymptomatic patients into an online environment, you're potentially reducing demands on clinical services. And again, increasingly we see these are sort of expectations of patients and clients around more patient-centered approaches. So Get Checked Online is certainly not the first program to have done this. Actually, one of the first programs was stdtest.org in San Francisco. We see major initiatives, particularly in Europe, involving population-level chlamydia screening in the Netherlands and in the UK. Some may be familiar with the I Want the Kit program in the United States, which involves ordering a self-collection kit for chlamydia and gonorrhea testing. There's one program in Canada, Get Tested, Why Not, which is done by Ottawa Public Health, which is a program that's targeting youth in the Ottawa area with urine screening for chlamydia and gonorrhea. So we're certainly not the first people to do this, and we've been able to sort of learn a lot from the experiences of others. You know, when we started to do this, we sort of set out, you know, what do we want to accomplish? What are our objectives? So we wanted to improve sexual health by increasing uptake and frequency of testing and leading to increased timeliness of diagnosis. We wanted to reach those populations at greater risk of infection and facing barriers to testing, including, not exclusively, but including, at least to start, our priority populations being youth and gay and bisexual and other men who have sex with men, as well as people living in rural areas. We aim to increase our STI clinic capacity, so to reduce wait times, have more capacity to accommodate people who are showing up for testing, and have better use of clinician resources. And they're doing this through a process of piloting, evaluating, and scaling up. There we go. We do know from some of these other studies that there have been very positive findings from these other pilot programs or research studies, some of which have been very large in scale. For example, in the Netherlands, over 40,000 youth participated in their first round of chlamydia testing, which was sort of a good indication that it's a popular service. In sort of follow-up work, many of the clients prefer internet-based testing to in-clinic testing with similar rates of positivity and similar rates of follow-up for treatments. And so we felt we were on a good foundation in terms of trying to develop this. But there were still many questions that we didn't know. You know, we didn't know what appealed to users or who would use it and when. Will this, in fact, lead to these objectives that we hope about of increasing test uptake and frequency, reducing undiagnosed infections? Are there differences between someone who tests online versus in clinics who get traditional pre- and post-test counseling and their knowledge of HIV, and so on? And so I think that these are all of the questions that we've been trying to sort of answer through our ongoing program of research. And that's what we will now shift and tell you about. So, Jeannie, over to you.
Thanks. And just so everyone knows, Mark is in Toronto today and I'm in Vancouver today. As I said, about 5 years ago, we began this endeavor, and certainly we didn't know then what we know now. But as you can see on this slide, we adopted a phased approach, which really allowed us to take our time, work through carefully some of the development of prototypes, build and test, work through in the phase 2 piece around developing great relationships with IT and others around security for the site, and ultimately this year launching the pilot test in BC CDC clinics, which is a very exciting piece, and then into the future aiming towards a province-wide scale-up. As Mark will show you as he changes the slide in a moment, the entire kind of cyclical process between constantly feeding back between clinicians and users and ourselves as teams, ourselves indeed in many cases as end-line users, has been really, really helpful at all phases of development. I mean, you can really see how, you know, until you start actually doing it, integrating the online system into the existing system, it's really almost impossible to fully understand the potential impacts. They can really only be understood through these feedback loops. And to do that kind of work, if Mark could just click, please, we required a bit of investment, not only on the program side, which was very significant from BC CDC and the Provincial Health Services Authority, and a huge realignment of existing resources with Mark and his BC CDC-based team. It also required some investments on the research side. You know, we've written a series of grants together, operating grants and FISI grants, as was referred to at the outset, and actually several other types of grants, to undertake everything from, and engage students, as I mentioned at the outset, to engage in everything from health equity impact assessments to the development of predictive algorithms to run in the background of the Get Checked Online component, which you'll hear about in a moment, as well as some work that I will tell you about in the next slide, please. So one of the earliest pieces in the developmental phase of our collaborative research and decision-making initiative around online STI service provision focused on trying to understand what young people wanted. As I mentioned, two key priority populations, men who have sex with men and young people, we really hope will be the primary users of our new online offer. And if you could go to the next slide, please, Mark. Thanks. We conducted a series of focus groups and interviews with young people from across Vancouver to ask them, even before the service was launched, how could they help us develop a prototype. And we've published quite extensively on these findings, but just in summary, to give you a sense of some of the most important things young people told us about seeking sexual health services like this on websites, is that they really wanted it to be practical, not esoteric, and not kind of theoretical. They wanted to have access to peer-generated information, but they also really wanted it to be professionally done, professional approaches to design and professional approaches to content. They were not interested, as Sarah's quote says, in talking or receiving answers from someone who sounds like they might have gone to the bar with you that night. They want to be, for them this is a serious issue and they want to take it seriously. As well, one of the key features that we learned early on is that the BC CDC, BC Ministry of Health brand, if you will, or organizational affiliation really means something. That it offers a real sense of credibility, and that young people early on recognize that. If you could go to the next slide, please, Mark. We also, in the developmental phase, spent some time really asking people to look at and talk with us, and these included interviews and focus groups with not only young people, but also with gay men and clinic clients, so people who were already coming to the face-to-face clinic service outlets. What would you like to see, or what do you think are some of the key features of being able to, as either your primary source of sexual health service or as an alternate source of sexual health service, what would that mean to you? What would that look like to you? What is it about internet-based STI testing that appeals to you? And over again, and I'm sure you're not surprised to see this, the issue of convenience, being able to access that any time of day from anywhere, being able to access immediate and private testing, consultations if there was an urgent concern, so no wait time. Of course, concerns about ensuring confidentiality and security were also paramount. So, you know, the back work on ensuring that has been really, really well done by Mark and his team at BC CDC and the IT and the privacy groups at the PHSA. People also wanted, users also wanted to be able to work in an interface that had features that were somewhat user-friendly and similar to things they already knew how to do. So it had to look and feel a bit like doing your email or sending a text or ordering something online. It couldn't be an interface, an internet-based interface that was completely new and foreign. And they wanted to be able to make choices. So choices about how and when they might, for example, receive their test results. And the message was very clear that if a test result came back positive, meaning the presence of one or more STIs, that there needed to be a method of delivery that was very sensitive and attuned to all of the privacy issues, but also attuned to the wants and needs of potential clients who would want to be able to come back and access some additional information and counseling. So we knew that those various needs and components would need to be built into the prototype. And so Mark and his crew began with a very it doesn't look much like this anymore in many ways. So, Mark, I'm going to let you give the 1,000-foot model, and then we can go from there.
So this was where we started. We started with a 1,000-foot model, just at a really high level, what we thought the program would look like. And this is what we used in the interviews and focus groups with clients. And essentially, just to describe for you the Get Checked Online program, because in a sense, it's sort of still these main steps. First, involving going to the website to get a requisition. So you create a profile, review the pretest information, complete an assessment that asks questions similar to what you might be asked in an STI clinic in order to recommend tests and tailor the information, and then print off a requisition for STI testing. You take that to second step, you take that requisition to a private lab. We're partnering with Life Labs in British Columbia to give your specimen. And in our pilot phase, it involves urines for chlamydia and gonorrhea and bloods for HIV, syphilis, and hepatitis C. We are also working in the future towards inclusion of self-collected specimens. In the third step, then, you receive a notification by email when your results are ready, and then you log back in to view your results. So essentially, there's one of three things that happens. If all your results are negative, you can review your test results online. If you have a positive result, as soon as there's a positive result, someone from the clinic will be trying to contact you, because that's the normal clinical practice, using the email address that's required to log into the service, or a phone number if it's provided. And then finally, if there's problems with the sample, sometimes that happens. There can be a need to talk to the clinic to sort it out. So we started with this 1,000-foot model and then shopped it around like crazy. So the next slide, one group that we did, so we knew we talked to sort of users and certainly took their feedback and we're using that to, make sure that we were meeting their concerns. But we also talked to providers. So we did focus groups with sexual and reproductive healthcare providers in BC and found a number of themes. And I think these were the four main themes. The first being that the feeling that internet testing program really reflected the inevitable evolution of healthcare. So not necessarily that everyone saw this as, the ideal way to offer testing, but it was definitely seen as inevitable and good overall in terms of shifting control of the patients, addressing testing barriers, and so on. But with also flagging that some of the benefits could be offset by perpetuating inequities. So if it's being used by people who already have appropriate access, that's not the best use of the service. Another theme was around the potential for personal harm. So again, anxiety at the receipt of a positive test result. Would the service be repeatedly used by the worried well, and would people really understand the limitations of testing that many providers try to convey in a testing encounter? Third, the potential for clinical harm. So if people are coming to the service and are getting inadequate or substandard care because they're either not getting the right pre or post-test counseling, not being offered the necessary tests, or not following up on positive results could lead to clinical harm. And then finally, many providers did see ways that they could integrate this service within their own clinical practice. For example, by accessing results online or using this as a referral, they would refer some of their low risk or as an initial triage of people to the service. So as I mentioned, we used that information to help us sort of then figure out what the design would look like. We also wanted to understand one of our target populations. Jeannie talked about youth, and so we also we collaborated with the Community-Based Research Center to assess the acceptability of internet-based testing in a national online survey of gay and bisexual men by including relevant questions in the Sex Now survey of 2010 to 2011. And this was really, we set out to determine the characteristics of heterosexual men who would find the service acceptable, and really sort of keeping in mind those questions around equity and access, with attention to 4 key domains. We had questions around sort of important socio-demographic subgroups of gay and bisexual men, so really to see whether intention to use or acceptability differed amongst different demographics, to see, if factors that suggested that people were technologically savvy or, that there was generally appeal of internet-based services may be associated with intention to use, looking at risk and markers of risk as wanting to know if, obviously that being a key outcome that we would hope people who are at higher risk would have greater intention to use, as well as questions related to healthcare access and testing and people's experience with delays in accessing testing or barriers to testing. We saw overall, we're quite pleased to see overall that 72% of heterosexual men surveyed across Canada intended to use the service. And this was not described as get checked online. It was just a very simple explanation of internet-based testing in general. And we surprisingly saw very little variation by characteristics in general. No matter what characteristic we looked at, the range was between sort of 65 and 80% in terms of acceptability. When we did our multivariate analysis, we found, kind of consistent with what we had expected beforehand, we didn't see too much in terms of demographics, in terms of difference in intention, other than we saw that younger men were more likely to want to intend to use an internet testing program. Bisexual men more likely, and straight identified men less likely compared to gay identified men to intend to use the service. Participants who answered positively on our questions that were set out to sort of assess people's sort of internet use history or technology use history, cruising for partners, looking for help information, or using a mobile phone for more than phone calls, were more likely to intend to use the service. We saw HIV positive men being less likely, which was consistent with what we heard in interviews, because HIV positive men are more likely to be able to access STI testing through ongoing care for their HIV. And we did see, and which was again affirming that we're on the right track, is that participants who reported some barriers to accessing healthcare and accessing testing, such as not being out to their primary care provider or delaying testing due to privacy concerns or inability to access testing, were more likely to intend to use internet-based testing. Just to finally, in terms of the development phase, I'm not going into this in detail, but the links will be on our website. And we did address specifically questions of equity and ethics. So in partnership, while working with Janine Farrell, who's an MPH student from Simon Fraser University, she conducted a health equity impact assessment for us, and looking at ways that GetCheck could contribute to reduce health inequities for populations with higher incidence of HIV and STI. We also came up with this interesting ethical question, because when you think about principles of informed consent, that's often very different from what we think about in terms of legal disclaimers for consent of an online service, which is more of the scroll down to the bottom and tick yes, as we all do. And so that's the question about how does one obtain informed consent to test an online environment. And we conducted interviews with potential users to determine their perceptions of this. And both of those reports are available if you are interested. So that said, that was all of our background work leading up to the pilot phase, and we have now entered the pilot phase, and the site is now live, and you can check it out at your leisure. I won't be going into more details about how the program works, but you can certainly find all of the information there on the website. And it launched in September this year with a focus on 2 clinics that are operated by BCCBC, and it's by invitation only at the moment. And early in 2015, we're doing a promotional campaign to gay and bisexual men in the Vancouver area, and that's our initial pilot phase. That said, as you know, we got funded to develop this program back in 2009, and we thought, okay, it's going to take some time, but we didn't really anticipate that it was going to take 5 years to develop. But looking, you know, it's actually not that surprising when you think about a complex health system intervention like Get Checked Online. You can see that along the way we've had to do multiple collaborations, multiple partnerships, and are dependent on other sectors within our health authority, within the health system. It's broken new ground, and there's a need to sort of think through new privacy requirements, think through new ways that we communicate as healthcare professionals in an online environment. And so, you know, there's has been an awful lot of work and effort, and actually health system change along the way that has sort of permitted this, and which Get Checked Online has actually spurred in some cases. So this is sort of our unofficial logo for the program, because this is how it feels sometimes, that it has definitely been a steady push uphill, but that the end is worth it, and we're very delighted that it's finally launched. I'll turn it over to you, Jeannie, to talk about that piece.
Thanks, Mark. And in really trying to continue to push that ball along and understand the processes and mechanisms that will help us get that ball or a block over the top, if you will, we also have been undertaking an institutional ethnography to really understand the factors affecting implementation and scale-up of the new online sexual health service approach in British Columbia. And this work is funded by CIHR. The work includes doing observational field work through working group committees and meetings at the BC Centre for Disease Control and the planning team. Researchers are integrated into those meetings, taking notes. They attend public presentations, note questions that are asked by the public, spend time in the field sites, the two implementation pilot sites, in-depth interviews with service providers, working group committee members, consultants that have been brought on board for things like the look and feel of the website, understanding and talking with staff responsible for informatics and online service scale-up, and even policymakers and administrators involved in very high-level decision-making that requires to unleash a program like this, as well as reviewing many documents pertaining to everything from privacy through to the Public Health Act. Next slide, please, Mark. In terms of preliminary findings, there are a few things that I'd like to highlight in addition to a couple of the points that Mark has already made. You know, when we have done this field work and interviews, it is very clear that accessibility of the service is one of the key features, and that there is a very widespread belief and perception that, you know, Get Checked Online has a great potential to improve STI testing provision, not only for MSM, men who have sex with men and young people, but also in general. It really is an attempt to potentially address, you know, the capacity issues within public STI HIV testing systems by shifting some clients from the more kind of human resource intensive face-to-face testing to internet-based testing. And so that was seen as a really great part of the potential of the initiative. Quality of care. Mark spoke to a moment ago some of the issues about clinicians and the prospect of clinicians losing some degree of control over service provision, and that indeed, you know, has been just a bit of a disconcerting notion across the board. But also, clinicians have been extremely progressive in their views around the ways in which online STI testing approaches also have the potential to potentially normalize STI testing and encourage people who might not already be engaged on a routine basis to step into that online sphere to access good quality care through an online avenue. Mark mentioned that you know, concerns about cost and some of the challenges facing an ever-contracting budget world, but an overwhelming demand world. And again, people within the system recognize this in terms of the so-called risk of being swamped by, the worried well or frequent flyers, those people who are, especially anxious about contracting an STI, but who might actually be at low risk. But most of the people that we've worked with throughout this particular study have really seen the online approach as being a more cost-effective manner for addressing some of those concerns than taking up valuable clinician face-to-face time at that front. The other point that I just want to make around demonstrating potential, and I think this is one of a really important finding of our work. There definitely is a desire to see this initiative scaled up in other parts of the province. But most people recognize that to do that across a province like British Columbia is certainly a long-term endeavor, and that there may be unique challenges in our more rural and remote areas and health regions that have funding implications, et cetera, than we see here in the Lower Mainland where Vancouver is located. So they really applauded the notion of piloting and scaling up in a very controlled manner, and that's something that we're taking very seriously into the future. Just as a closing note on this, it's absolutely clear that the new testing, internet testing service is really viewed as one more tool in the toolbox for sexual health service provision. And it's, I think, a really exciting piece that's potentially viewed to be potentially feasible and to contribute to, the larger picture of success within the larger sexual health care system in British Columbia. And speaking of the system improvement aspects, over to you, Mark.
Great. So I realize that we're, in the last phases of our presentation, and we're now just starting to talk about FISI, which is sort of one of the genesis for this policy rounds. And as you can tell, we'd originally, we were originally awarded a FISI grant back in 2011 to assess the impact of an internet-based testing program. But due to sort of, I think, the realities of implementing an intervention like this, we're quite happy to be successful in our application for renewal, which has then sort of furthered this to, over the next few years, also not just assessing the impact, but looking at optimizing the impact of our internet-based testing program. So even though we are now just beginning to implement the study activities related to this as we've just piloted, I think it's still the opportunity between these two FISI grants has allowed us to not just do some of the preparatory work that was needed, but to establish the foundation for us to really fully evaluate the impact of our service. So just to tell you briefly about these two studies that we have, first just to acknowledge we have a very large study team which includes researchers and knowledge users from across Canada, across BC, across Canada, and internationally. This is now a study team which is really getting rolling now that our program has finally gone live. But just certainly want to acknowledge them and all their impact. So first, just to tell you briefly about our first FISI grant, and even though the funding for this is wrapping down, we've been able to, figure out how we can implement some of these activities going forward. And certainly our goal was to really understand the health and system impacts of our internet testing program, looking really at understanding impacts at multiple levels. So with a focus at an individual level, at a population level, and at a health services level. So for example, we, just to again confirm sort of what we know about the acceptability once it goes live, are we mitigating some of the existing barriers? At a population level, are we really reaching those populations that we hope to reach? And are we seeing changes in test frequency, for example? And are we seeing some of those anticipated impacts on health services in terms of increasing capacity and changes in staff configuration? We've done this again by sort of best practice recommendations using a multi-method approach, including the focus groups in the online community survey, the STIs survey that I've discussed already. And now going forward, we're looking at methods such as using a virtual cohort of administrative data to understand testing and diagnosis patterns before and after implementation, doing a client survey of users of GetChecked.Online and comparing them to clinic clients to see how there may be differences in who is accessing online versus not. Doing interviews with GetChecked.Online users to understand more about their experiences of using the system and why they use the system, as well as understanding using health services data to understand the impact on clinic services. The second FISI grant, which is sort of our renewal, takes us one step further. So we'll be using the findings from our first FISI grant, as well as new research that we've been doing to better describe, or we will be doing, to describe the population impact of GetChecked.Online. So really what we're looking at here is how do we optimize the impact, and we've looked at this in two ways: optimizing the service, so building on that feedback we had from providers around concerns around poor clinical care. For example, if men who have sex with men are not getting tested for rectal infections or throat infections, which they would otherwise in a clinic setting, we are optimizing the service by adding in self-collected specimens and really evaluating those in terms of acceptability. We also have an opportunity with our promotion to men who have sex with men, which we've done using promotional code, to really evaluate carefully the impact of different promotional strategies in different settings accessed by men who have sex with men in Vancouver. But ultimately as well, we want to be able to try to optimize the population impact, and that's not really something that you can measure, so we're doing this through mathematical modeling and economic analysis by seeing, what did we achieve and how can we potentially optimize it for different populations, particularly of men who have sex with men, to have the best impact. The methods for this second survey, so in terms of optimizing, or second study, in terms of optimizing the service, we'll be looking at various sort of program metrics and results related to self-collected specimens. And with our targeted promotional campaign, where we're doing a social marketing campaign using those codes to analyze the metrics, looking at positivity, for example, in different settings, as well as doing a community intercept survey to understand awareness, perception, and use of GetChecked.Online. For optimizing the impact, working with Dan Coombs at UBC, looking at mathematical modeling to develop a set of models to describe the testing patterns, incidence, and prevalence in Vancouver MSM, and extrapolating that then using SexNow data to Toronto and Montreal. We'll also partner with Sterling Bryan at UBC to conduct an economic evaluation, which uses a healthcare sector perspective to assess the cost effectiveness and cost utility of GetChecked.Online. So we're quite excited about the next few years as we're sort of actively getting into the evaluation of the impact. Move forward. Over to you, Jeannie.
Okay, I'm very, very briefly here. Mark and I both really wanted to highlight the fact that, the default setting at the moment is sort of almost like universal screening for all clients, and we recognize that that's not the ultimate goal of, having a risk scoring algorithm running in the background of GetChecked.Online is actually, necessary in order to optimize cost effectiveness and really, address and limit the number of individuals who might be confronted with unnecessary tests. So I really want to highlight here the work of one of our PhD students who has recently completed her PhD, Lola Falasanu, who used routinely collected data to derive the risk prediction rule for GetChecked.Online. And this is a really novel and innovative piece. And I'll just ask you to skip to the next slide, Mark, this prediction rule uses several predictors, young age, race, ethnicity, multiple sex partners, previous diagnosis with infection to, identify, and as this analysis shows you, to identify a very acceptable proportion of the population that needs to be screened. I'll refer you to these publications so you can spend a little bit of time thinking about this. Maybe the next slide as well, Mark, just to say that in addition to validating this risk scoring algorithm up against data from two different time periods, 2000 through 2006 and 2007 through 2012, Lola also geographically validated the risk estimation algorithm, and that both those algorithms have performed very, very well. Next slide, I think, Mark. We also will be continuing throughout the scale-up phase with focusing on understanding how Get Checked Online plays out with young people, not only within the Metro Vancouver community, but also outside of the Vancouver community. And the approach here will shift more. We'll continue to do interviews, but we're also engaged in an online survey, one that will be implemented online at their first visit to Get Checked Online, and another, again, 3 months afterwards. And we're really excited about moving forward with this, considering the recent soft launch of Get Checked Online. So next slide.
Great. So, so just to wrap up then, we wanted to share some of the lessons that we've learned. I realize this has been a bit of a whirlwind tour of all of our research activities over the last 5 years and sort of going forward into the near future. And certainly either Jeannie or I are happy to follow up with you afterwards if you have any specific questions about anything that we've talked about. But just in general, I wanted to at least share from using my program perspective hat, what for me has been some of the lessons that I've learned along the way. I mean, this is, you don't get taught a class in medical school about how to deliver online interventions, and I've certainly learned a lot through this process. Certainly, it's definitely resource intensive to develop these kinds of e-health services and interventions. And really, and practically speaking, I feel in today's healthcare system where there's not really a lot of luxury or a lot of room for sort of trial and error, you really get one chance to get it right. And so I have seen how this integrated knowledge translation approach has been really essential to assuring the optimal design for the best chance of the optimal impact. I think the other piece is that, that catch-22 of that they're sure that there's, and that there may be, we're not going to adopt a population intervention until we know its impact, but we can't evaluate it until it's implemented, really speaks to the need that this kind of innovation requires careful evaluation. This is a novel intervention, at least in Canada or in BC, with unknown impacts. We don't know what the ongoing financial implications are, so there's a high degree of uncertainty and potential risk involved with innovations like this. So having a carefully designed program of research with stage implementation evaluation is reassuring to stakeholders, and that's something carefully that we've been very deliberate about engaging stakeholders all the way through in terms of this process. And I guess my final point, project timelines. Really, what we thought we'd given ourselves enough time, and we needed to add at least 2 or 3 extra years. So really, and unfortunately, that's one of the things where, research grants where there's sort of tight deadlines or a limited duration of funding sometimes runs up against some of these population interventions that are being implemented in the health system. And definitely there's a need to be flexible, and I'm certainly grateful to CHR for the renewal of our FISI grant to allow us to fully implement the activities of our study.
And I guess from a researcher's perspective, although I want to also acknowledge that Mark is as much a researcher as he is a program person. But, I think that this is a really great example of why public investment in not only applied research is a tremendously productive enterprise, but also some of the things that I didn't get to share with you today around, investments that have also yielded very fundamental theoretical work around gendered stereotypes online, for example. That kind of combination of, pure and applied research, I think, is really, really, this is a very promising area. I hope that as we move forward with the new foundation schemes and approaches to operating grants at CIHR, that it might become easier to sustain this kind of approach. But I can tell you that at any point this could have fallen apart if any one of our grants hadn't been funded, or from a 3-year renewal onwards. I also think that the kind of very genuine reciprocity that has existed from day one between decision makers involved in this initiative and researchers involved in this initiative is absolutely essential to its success. And I think each of you will probably have experiences with that in your own context, but the co-development and co-implementation of effective research and practice and community partnerships has been absolutely essential to producing credible and relevant evidence for the development, pilot testing, and implementation of the online program. And finally, I wanted to say a word about operating grants as training opportunities. you know, Mark and myself and our colleagues and students have really engaged in a process of putting together a suite of operating grants and FISI grants and others to not only do the work, but to also show students how we can work effectively together in a genuine team. And I think that our students really embody this in their theses, in their publications, their dissertations. We've had more than 10 papers coming out of this so far. All of them have involved students in one way or another. We've had several MSc theses and PhD dissertations, and so I think that it's really exciting to see this kind of line of investigation around internet-based testing also feed a broader, and if you go to the next slide, not only feed students learning around online systems, but also a broader research and training agenda in Canada around population and public health intervention research. Mark, go ahead.
Sure. Oh, well, I'll speak to the remaining. So I think the other pieces, benefits, are really that I think the combination of the research funding and the programmatic funding has really leveraged off each other for greater impact. And we've been able to do things that we couldn't have done just using programmatic funding alone or research funding alone. I think we really hope, like, one of the benefits I do see is that the demonstrating the value of this approach could lead to new models for integrated service delivery and evaluation. And the other piece is that we, both Jeannie and I, as well as many other people on our grants and teams, have complementary stakeholder networks in public health, in academic, and community networks, which has really allowed for greater opportunities for knowledge translation at these multiple levels. And finally, it's fun. Jeannie and I both have a lot of fun doing this. It all started because of essentially a conversation at a conference back in 2008. And I think this has been really valuable for both of us and really enjoyable with everyone that we work with. So just, there have been so many people that have been involved with Get Checked Online, too many to thank, but we have many colleagues at BCCDC, at UBC, community organizations, public health, regional health authorities, et cetera. But did just want to acknowledge in particular some of the efforts of the people here on this team who've sort of really been some of the key players, either both on the programmatic and the research side for this initiative. And then finally, just let me move one more. I can do that. Yeah, so certainly if you have any questions, all of our reports and publications are on our WordPress blog, which is bclovebytes.wordpress.com. You can reach us at our program email, or I'm also on Twitter, although probably not as active as I should be, and you can reach me that way as well. Thanks.
Well, thank you very much, Mark and Jeannie, for your very engaging presentation today. It sure does sound like you guys have a lot of fun while doing some meaningful work, so that's something to aspire to for all of us. I reclaimed the presenter ball over here, so I'm just going to flip to the next slide, which is our Q&A portion, and bring us to the Q&A portion of our webinar today. So if you do have some questions for Mark and Jeannie, please put them in the chat box, and I'll direct them to our speakers. If you haven't had a chance to contribute to the chat yet, you'll just find it on the bottom right-hand side of your screen, and you can type your questions in at any time throughout the discussion. I'll just read the questions aloud and direct them to the appropriate presenter, and we'll have just about 20 minutes for discussion. So maybe to get the Q&A started off, if you don't mind, I could ask the first question, if you don't mind, Mark.
Sure.
Just wondering, this takes us a little ways back in your presentation, but when looking at all the barriers, and I think it maybe was Jeannie who presented this, looking at all the barriers to conventional service delivery and accessibility that impact STI diagnosis and treatment, how would you advise folks who are looking to tackle this problem by taking like a first step toward making meaningful but manageable change? What would you say would be a good jumping off point?
It's a good question. I mean, I can tell you how we approached it. I mean, right at the very beginning, we looked at, actually went through a process of, well, first we looked in the literature to really see, okay, what are all of the barriers that people have reported related to access of testing? And so we started with what was in the published literature. We also then went through an exercise where we said, okay, for these barriers, which of these is potentially mediated by internet-based testing, and we're able to, obviously it's not going to solve all access issues, right? I mean, the fact you might have to drive to a clinic, you know, it's not going to help if you also have to drive to a lab to submit your specimens. So we kind of use that, starting with the theoretical, and then really tried to see how that could potentially be addressed, and that's actually now informed our next phase of research. So we're now looking at really testing whether those barriers that we thought we'd potentially be able to mediate through this intervention, if we have or not.
Okay. Thanks, Mark.
No problem.
I do see a question here from Greg Penny. It says, thanks for this presentation. I have a two-part question. How will you be addressing low SES populations who often do not have access to internet or mobile technologies? Was this addressed in your health equity impact assessment, and have you applied a health literacy lens to ensure the information is accessible, etc.?
No, those are great questions, and certainly I can speak to the first, and that's one that sort of comes up a lot. And I'll admit to being very, I sort of changed my thinking about this as we've gone through. When I first started in this program, I sort of said, well, it's not going to be a service that's used by everyone, right? So it's clearly like folks in lower socio, you know, potentially don't have access to the internet or may not be using the service, and just had originally thought, well, you know, that's part of the limitations of the service. And I was really challenged actually through working with Janine Farrell at the Health Equity Impact Assessment to sort of change that thinking into that, no, we have to think about how this is a service that's potentially used by everyone. So that definitely has been one of the things that we have been looking at and are continuing to look at. So one of the grants that Jeannie and I have, Jeannie has led that I'm part of that's being submitted is actually looking at that question of more socioeconomically disadvantaged youth and would they be able to use Get Checked Online. Even in speaking, you know, some of our innate assumptions is that, well, people, you know, who maybe don't have computers wouldn't use the service, but that generally when we've spoken to actually people who are sort of working in the front line or people from those communities, generally there's a sense of like, oh no, I'd still use this, but I could figure out a way to use it. So I think it's helped us as well to challenge some of our assumptions, but I definitely agree that we have to think very carefully, particularly, you know, also thinking about really isolated communities, for example, where there may not be sort of strong internet access or some of those features as well. So we hope to, the equity impact assessment we did was just for the essentially scoping out the idea and what are the potential impacts, and we'll be returning to complete that assessment once we've sort of launched and have had a sense to see what the impacts are. I'm sorry, can you remind me what the second question was? Amanda?
The second part of the question was this addressed in your health equity impact assessment? Oh,
yes. Okay. So there you go.
Yeah. Okay. Thanks, Mark. There's another question here from Diane, and she's wondering, what's the initial uptake of e-testing, and how are these services advertised?
Great question. So we have just gone live. So at least I can't really speak to confidently yet to what our uptake will be, but I have high hopes. And we're doing a fairly slow and passive recruitment. Just as some of you know, there are other sort of health system interventions going on, and we're trying to figure out how this fits in with that. But so what we know is that the uptake has really varied, and I think it does depend on things like promotion and access models. If we look at other examples from other places. So if we look, for example, at San Francisco that had one of the first online testing models, they had a publicly available, accessible, anyone could use it, and it was widely promoted. And it was so popular that they actually had to stop because they didn't actually have the resources to sustain it. So that's some of the delicate balance that we're trying to figure out as we go forward and why we're trying to do this in a more staged kind of approach. For our initial phase of the pilot, it is through invitation only and through promotional code, so it's not publicly accessible yet, but that may be something, and eventually down the road, you know, if it's showing the benefits that we think it has, ideally that would be where we would like to go.
Great. Another question here from Vanessa is, since in many provinces the address of the case determines what health area the case is attributed to, how have you managed to deal with jurisdictional issues relating to the place of residence of the person requesting online testing? I.e., is the service only available to a particular catchment area?
Another great question. So for our pilot right now, it is centered primarily on Vancouver, and the way that the program works is that one of the clinics that are operated by BC-CDC sort of assume responsibility for all of the clients. It's kind of like a virtual extension of our sort of physical clinics into an online environment. There's actually been, we are having discussions right now in BC because there's a lot of, one of the things that I found with this intervention and talking about the program is that it's very appealing to many people and very popular, and we've actually started engaging with health authorities at their request to talk about how this could be scaled up in their regions even before our pilot launched. And so we are thinking through some of those issues around reportability, and essentially, you know, we're trying to align within sort of what the current reporting practices are within British Columbia.
Okay, great. Another question from Chris Cash. In the pilot project, are you seeing clients, are you seeing clients that see this as a convenience and previously accessed clinics, or are there high-risk clients not previously accessing services who are now using this?
That's a great question, and that's one of our key things that we're trying to evaluate with the impact. We suspect that we're going to see both. And so, for example, when we're right in the middle right now of developing a social marketing campaign to gay and bisexual men in the Vancouver area, and those are both aspects of the campaign that we're emphasizing. We're emphasizing the convenience of the campaign for men already engaged in testing, but maybe are not testing as frequently as they want to or should. And second, we're also emphasizing the privacy and sort of confidentiality of the service to try to engage some of those people who have those concerns and are not accessing testing otherwise. But it's also a bit of a question. There's not really great evidence in the literature around the broader impact of these kinds of interventions, looking at those types of questions. So I think this is sort of a really important gap to try to fill.
We do know from our preliminary work, particularly with young people, that there is a great appetite for having an alternative. And just to revisit some of the thematics, perhaps, of an earlier question, you know, that people who are socially disadvantaged by any number of means, including their socioeconomic status, also face significant barriers in attempting to access conventional face-to-face clinic-based services. The online option is not meant to replace those kinds of clinic-based services. It's meant to offer one more alternative, and certainly through our work around health impact health equity assessment, and through our developmental work with regards to the web interface, the approach, the notion of not reproducing all kinds of barriers online that might exist already in conventional approaches. We've really tried to keep that in mind, that we don't want the online system to become an inequity exacerbating intervention. Rather, we'd really love to see it become an inequity reducing intervention.
Thank you, Jeannie. We have another question here from Cheryl Prescott. She says, thanks, this is an exciting endeavor. Can you speak to system-level barriers, such as the decision to use private versus public lab access? Do clients have the option of testing without a personal health number? Example, no access MSP.
No, great question, and thanks, Cheryl, for that. Yeah, definitely there, you know, when you're trying to develop this is a low threshold testing model, so people aren't required to show ID, they aren't required to show their MSP care card. And so certainly, I mean, that is a kind of thing that you can do in a clinic setting where you have control over that, but when you're trying to do it in an online and involving private labs, it does make it more complex. So the way that we have set this up is that still, even when clients are presenting to a private labs where usually a care card is required and proof of identification is required, we've been able to set it up by using a contract with the labs directly, that's not the case for GetChecked Online users. You know, that's not to say that some clients might be fine using their care card, but really we know that for many people that is a barrier, especially if you want to be reducing barriers for people who are already concerned about their confidentiality and privacy.
Okay, thanks very much. I have another question here, just relating again to the advertising and as well as the different age groups. So a lot of the focus, it seems, is on youth, but has there been any consideration for expanding this program to different demographic groups like seniors?
So great question, and I think we're really, as we're getting into this, we're realizing that there's many different potential applications for this beyond the populations of youth and gay men and monosexual men, and really those are kind of really just sort of like organizing lenses for us as we're starting at sort of priority populations, knowing that these are populations where the acceptability is already very high. We know that from the literature, and it's a good place to start, regardless of the fact that there's a higher prevalence of disease within these populations. So I think, as we're starting to talk with different regional health authorities about the program, we're learning from them about, that they are thinking of different ways in which this could be implemented or different priority populations for their region. Seniors hasn't yet come up, but certainly, people have talked about, well, maybe we would like to promote this to sort of an entire population, but in a smaller rural community where there's not such good access to testing services. And so I think, really, I think that's the exciting dialogue that's still to come in terms of trying to figure out, what are the best ways to implement this service. And we really do see that the pilot and our promotion of sex with men is just part of that initial step in trying to think through how do we expand this to sort of other populations and across BC.
Thanks, Mark. We have another question that just came in here from Leo Materni, wondering if you missed the opportunity with this e-health aspect to educate and provide counseling. Also, without the physical exam, are you missing other diagnoses, i.e. warts or rashes?
It's a great question, and those are some of the themes that came up in our discussions with the providers as well around this, and are things that we're sort of trying to be attuned to and mitigate the risk of that as much as possible. So I think, I think if you were to say, there's no argument that if someone had the ideal clinical encounter where they felt comfortable disclosing all the right information, the provider felt totally comfortable, it was like the perfect clinical exam and all the tests being offered, then, yes, that is a superior form of the clinical engagement than an online interaction. But we know that that clinical reality is not necessarily the case. And we know that, with sort of some settings, there may be abbreviated pre-test counseling. There may be, people reluctant to disclose the right information to guess the test that they want. So we see these as sort of the same kind of risk, but just in a different setting. Those are also, though, some of the key outcomes that we are trying to assess. So we are looking carefully at whether people's knowledge differs. So if someone who goes through a clinical encounter and has her traditional pre- and post-test counseling, say 3 months after the fact, is their knowledge of HIV any different than people who've gone through it in person? We also have a very clear, as part of the program model, if people have symptoms of any nature or they're notified that they're a contact, they're advised to go to a clinic because they may need other tests or they may need other treatments. So yeah, those are very valid sort of like potential clinical risks and things that we've tried to mitigate and are things that we're continuing to measure in our evaluation.
Thank you, Mark. I just want to turn it over to both Mark and Jeannie again to see if you have any sort of wrapping up comments or thoughts for us just as we get to the end of the presentation here.
Jeannie, do you have anything?
I know you've been on the spot a lot today. So.
I think this has been a great opportunity, and as Mark said, we're happy to entertain additional questions after the fact. It's just been a really very productive, effective partnership, and we're grateful to CIHR for funding us over these years, and we're hoping that other people in other jurisdictions might be interested in trying something like this into the future.
Yeah, and I guess I just also want to acknowledge that we couldn't have done this work without sort of the health systems environment in which we live as well. And I really want to support or sort of give a shout out to the BC Centre for Disease Control because they've been quite willing to sort of support and actually actively seek out these kinds of innovative approaches. And I think that that's been sort of one of the fundamental factors is having an environment that actually permits and sort of supports this kind of work. So certainly, I just want to acknowledge that as well.
Great. Well, thank you very much to both of you today for joining us, and the work you're doing is very exciting, and We're glad that you're on sort of phase 2 of the FISI, and we look forward to hearing more about it as you move through to the final stages, and look forward to having you on again for another session down the road.
We'd love to.
Great. So in the meantime, I just want to thank all the participants for joining us here today and for your very thoughtful conversation through the chat function. This is part of a webinar series that we plan to hold regularly, and your feedback is going to help us make improvements as needed to this series. So once the webinar ends, you will see a pop-up poll on your screen. So if you just take a few minutes to kindly fill it out, your opinion really does matter to us, so we'll thank you in advance for completing that. And then we'll just wrap up again by saying that, here's some contact information if you would like any more information from either the presenters or from CIHR on future policy rounds or any of our work here at CIHR. And we will be providing you with a copy of today's presentation via the WebEx session, and you'll notice that through a pop-up window as well. They'll allow you to download the document. If you'd like to follow up, again, with either of us here at CIHR or with the project team, the information is available. So we just want to thank you again for participating today, and we'll look forward to hearing from you again soon.
Great. Thank you.
Good afternoon. Bye-bye.